Okay. So there we go. It's 7 o'clock on the dot. Good evening, everyone, and welcome to this month's edition of Wax and Clinical. We are very excited today to be having a presentation by Dr. Jack Biko. Unfortunately, Dr. Biko is not able to be here in person due to personal reasons, but he has done us the incredible favor of recording his presentation. So we'll be going through the presentation, and then his partner in his practice, Dr. Tato Maudu, will then be taking questions during the Q&A. Just a little bit more about Dr. Jack Biko. Dr. Biko is a specialist obstetrician gynecologist. He also has a PGA in assisted reproduction from Warwick University in the United Kingdom, an MSc in human reproduction from Valencia University in Spain, and a certificate in advanced endoscopic surgery from Kiel in Germany. He's also the current president of SASREG. So we're very honored to be going through and hearing from him tonight in terms of the topic of the infertile man. Dr. Tato Maudu, who works with him, also is a specialist obstetrician gynecologist, and he also has a certificate in reproductive medicine and endocrinology and infertility from the College of Medicine of South Africa. So thank you so much for joining. I'm going to hand over to Dr. Maudu now, who's going to start the presentation. If you have any questions, you're welcome to put them into the chat, and then we'll address them at the end of the session. Dr. Maudu, I think we just need to check the sound. I can't hear the sound.
Netcare.
Can you hear it now?
There we go. Yeah, we can hear it now. Thank you so much.
Thank you, everybody.
We are going to talk about the man of infertility. We'll go through all the essential aspects of infertility, and we'll talk quite a bit about male health, because infertility is just one sign of a problem within the health of a man. Now, if you want to talk about male infertility, we better start by defining what is male fertility. Now, male fertility is the ability to produce and deliver by normal sexual intercourse and ejaculate containing spermatozoa with the capability of causing conception in the partner at the normal rate of 20% per month. Now, what this statement means is that in a couple where there are no reproductive problems, where there are no health issues, it will take the couple at least 6 months to 1 year to conceive. This is very important because frequently we get approached by patients 2 months, 3 months after getting married, and then they come to the doctors to complain that they're struggling to fall pregnant. We essentially just have to reassure our patients and inform them that it takes long to fall pregnant. So it is normal to spend a year before falling pregnant. So we should reassure patients. We shouldn't be too concerned that if after 3 months, 5 months, they're not pregnant yet, they shouldn't be too concerned. It takes quite a bit of time for them to conceive. According to the WHO, 1 in 6 couples have issues with fertility, which means that all of us, whether you're a GP, whether you're a physician, whether you're a urologist, whether you're a nurse, you will see patients with infertility because it is extremely common. We also know that men contribute up to 50% of couple infertility. However, this is not spoken about. We often see couples coming to us with fertility and then we diagnose male infertility, but then families would assume the problems with the woman. They never assume that it could also be the man who has a problem. That's why this talk, I think, is so important. There are trends in terms of reproductive health all over the world. We can see that in most first world countries, since the 1970s, the average family size has been reducing and reducing and reducing. Currently, in most first world countries, most families have 1 or less children, 1 child or no children. There are a few countries, especially in our continent, where the families still have a lot of children. In fact, if you look at the data from the UK, almost 50% of families or couples there have only one child, and about 40% will have two children. Majority are up there, you can see. Very few couples have got more than two children. This means that the replacement of the population is lacking because we're producing less children than we actually are. If you look at our continent, it's a bit different. In the center of our continent, there's still countries where people have got 6 children, 7 children. In Southern Africa, it's still an average of between 2 and 3 children. Now, the problem in Central Africa and West Africa, where those who have kids, have got lots of kids, is that there is a high incidence of infertility there. And it is not seen because those who have children have a lot of children, and those who don't have children, therefore, don't seem to be very important. It's a big problem because the problem with secondary infertility is massive in Western Africa. There has been many publications about the decline in semen quality. Levine and his group did a study in North America and in Europe, and they assessed semen quality, semen counts, sperm counts in male over a couple of years. What they concluded in their 2017 study was that there has been a 60% decline in sperm counts in men in the Western world, North America and in Europe. It's stunning. I mean, if you look at the data down there, in 1989, 64% of our sperms were regarded as normal. In 1989, 64% of our sperms were regarded as normal. In 2005, we regarded 41% of our sperms as being normal. Is that being normal? So if 41% of your sperms were normal in 2005, we would say that you got a normal sperm parameter. But in 2010, it dropped to 5%. So a man that I see today with a 4% normal sperms, I say you got a good sperm morphology. Today, we say 4% is a good morphology. In 1989, we said 64% of normal sperms is a good morphology count. But this is now in the West. What is happening in our continent? There has been a recent publication, last year's publication, from a group from South Africa and Nigeria. The title of the publication was Trends in Semen Parameters of Infertile Men in South Africa and Nigeria. This was a retrospective study, and they reviewed the semen analysis of men in South Africa and in Nigeria. This reviewing was done on over 17,000 men, and their semen was reviewed in 2010, values of 2010 were checked, compared to the values of 2015 and the values of 2019. The aim was to see what is happening with the trend of sperm parameters over that period of about 19 years. There were very interesting findings from the study. If I have to summarize it, in South Africa, there was a 55% decline in sperm morphology. Morphology referred to are the sperms looking normal or are they abnormal? There was a 55% decline in sperm morphology in the 19 years between 2010 and 2019. So in 2010, the average morphology of South African men was 8%. In 2019, it dropped to 4%. And I must say, in our practice as well, when we do semen analysis, the majority of our guys will have a morphology for around 4%, maybe 5%. I don't really get 6, 7, or higher morphologies in our practice. It's mostly around 4 or 5% of the normal guys. And then it obviously goes quite low to less than 2%, 1% in those guys who have significant problems in their semen analysis. The biggest problem in Nigerian men was the very high, significantly high decline in the movement of the sperms. The movement of the sperms over the 19 years dropped by 87%. Okay, granted, majority of Nigerian men were older men compared to the South African men. In South African men, we had all races, younger folks. In Nigeria, it was only Africans, but generally of a more advanced age. But still, a decline of 87% is extremely worrying. Other factors which dropped significantly over the past 19 years, not actually 9 years, not even 99 years, is the sperm concentration. It dropped in South Africa by 7.4%, and the volume also dropped significantly in South Africa. Very worrying trend indeed. So in Asia, also they produce their own studies there. They check the temporal trends in semen analysis, because this checking of temporal trends started in North America and Europe, and then the Africans did it, and then the Asians also did it to see what's happening in our populations. In Asia, they actually checked many men, over 300,000 men, and they found the same trend. The trends is that the sperms are coming down, and coming down, and coming down. So the group that did the 2007 study, Levine's group, then redid their study. And this time, they did a global study, not just a North American and a European study. They got all the data from all over the world to see what is the global trends in male health. As you can see from the data, initial study was only in North America, and now they did globally all over the world. And their finding was also conclusive. They concluded that there was a worldwide decline in sperm counts all over the world. All countries were affected, all countries were involved. And what was worrying was that that decline in semen parameters was occurring at a very rapid rate. It was really concerning for all those who are involved in male health care. The question is, what is happening? Why are men being threatened like this? Why is men's health being threatened like this? Studies were done, and then what was actually found, what was very interesting, was that over the last 60 to 70 years, as the sperm counts were going down, that was corresponding to a time when there was a rapid increase in the use of pesticides and chemicals in the agriculture sector, in the home cleaning sector, in the beauty industry, the mascara, facial things. All those things contain microplastics, chemicals, and it's thought that some of these chemicals are actually harmful to our health. In fact, it has been reported that some of those chemicals are part of the so-called endocrine disrupting chemicals. Now, endocrine disrupting chemicals or mixtures, these are chemicals or mixtures that interfere with any aspect of hormone action at any time of development or during the life course of a person. Now, these endocrine disrupting chemicals are mainly estrogenic, or they're pro-estrogenic, or they are anti-androgenic. You can definitely imagine their effects on the male if they are estrogenic and anti-estrogenic. The effects will definitely be massive on the male, and thus the changes that we see in our semen parameters can be ascribed mostly to these endocrine disrupting chemicals. These chemicals are ubiquitous. They are everywhere. When we clean our houses, we use them. Like I said, in the beauty industry, they are there. The food that we eat, some of them have been sprayed with these chemicals, so they are all over the place. But how do we get these chemicals? How do they get to our gonads? We know that what is known is that these chemicals affect 3 generations. They are transgenerational. So if a lady is exposed to these endocrine disrupting chemicals, and this lady is pregnant, many of these chemicals are going to cross the placenta. So this lady will be affected, and then her baby, the unborn baby, will be affected. But that unborn baby has gonads, and those gonads have got gametes. So in other words, that unborn baby will have ovaries or testes, and those ovaries or testes will have eggs and sperms inside them. And those eggs and sperms of the unborn baby are going to be affected. So that when the unborn baby's child is born, that unborn baby's child will also be affected by the chemicals of which this lady got affected with. In other words, what happened to my grandmother will be expressed in me. So, ladies and gentlemen, if I make my assessment of the current situation with endocrine disrupting chemicals, maybe wrongly, but I can only come to a conclusion that we as men are born with messed up sperms. It might not be our fault. Maybe our grandparents were exposed to these bad chemicals, these bad endocrine disrupting chemicals. And because we were in our mother's wombs, because our mothers were in our grandmother's womb at the time, they got exposed, and that's how we got exposed. And therefore, if we get tested for these chemicals, it might not be found in our system because it was affecting 2 generations ahead of us. This is worrying. It is indeed worrying. But the decline in semen parameters is just one problem. Men's health is a big issue. The decline in semen parameters is just but one problem. There are other problems associated with the increased use of chemicals in humans. What has been found is that there's a disturbing trend in men's reproductive health. There has been a parallel increase in testicular germ cell tumors as the sperm parameters have been declining. So at the same time as our sperm counts have been dropping, there has been a progressive increase in the diagnosis of testicular germ cell tumors. And sadly, these testicular germ cell tumors also affect young males. Can we ascribe those to the chemicals that we're using? We are not so sure, but there is definitely this parallel between the declining sperm counts and the increase in testicular germ cell tumors. It is indeed a worrying trend. And then there are a lot of other factors that are involved in the poor outcome of reproduction. Our lifestyle has changed a lot. Smoking is all over the place. We don't live well, we don't eat well. There are various factors that affect our hormones. And then there are lifestyle factors that impact us negatively. We have to age, it's part of life. Can't change that. And we can't change our genetics. But our lifestyle, we can do something about it. Now, if we compare ourselves to our cousins, chimpanzee, you can see the chimpanzees, they've got 10 times bigger testicles than the average human being. They produce 600 million sperms per ejaculate compared to us men at about 39 million per ejaculate. But why? Our cousins live a natural life out there. Everything is exposed, nothing is covered, plenty of fresh air all over the place. We are tight. We wear tight clothes. We are hot. Everything is tight and learning, we've got laptops in our laps, there's phones in our pockets, it's just very hot. All those things can contribute to our few sperms that we have, to the increased abnormalities in semen parameters that we have. So lifestyle itself is a big problem, and something that is manageable, that can be spoken about to our boys and our men. We'll talk about this probably later, but our lifestyle has a significant bearing on our reproductive outcome. Sometimes, especially if you go to gym, you get these big guys who abuse steroids. Steroids are nice in the sense that they make you look good. They make all the muscles in the body grow. These guys look really big, but it's a problem. Steroids impair sperm production. So the testes produce steroids, corticosteroids normally. And then those corticosteroids will interact, negative feedback, with the brain in terms of production of FSH and LH. Now, if somebody takes exogenous testosterone, like some of these post guys do, you are also telling the brain that, listen, the testis is producing a lot of testosterone. Now, the exogenous testosterone does not cross the testis barrier. So you're taking a lot of testosterone, but within the testis, there's no testosterone because now you shut off the production of testosterone in the testes. Now, for sperm production to occur, we need to have high levels of testosterone within the testes. So if we take exogenous testosterone, there's going to be very, very, very low levels of testosterone in the testes because we have shut down the production of testicular testosterone. This will then result in impaired sperm production. In fact, this will lead to azoospermia. So we sometimes see these big guys coming in with their partners with infertility, and we just give them one look and we know what is the problem. Do blood tests, you can see testosterone levels are high, and just tell the guy, my brother, you have to stop this testosterone. They make all the muscles grow in the body except for the muscles in the testes. They destroy your testes. Luckily, it is mostly reversible. Occasionally, you'll get reports that there's a big guy, a fit guy who just dropped dead. The guy was fit and he just dropped dead. And the reason why they die so suddenly is because these steroids, these abusive steroids, like I said, they make they cause hypertrophy of all muscles, including hypertrophy of the cardiac muscles. So if there's hypertrophy of the cardiac muscle, it means that the cavity inside the heart becomes smaller and smaller as the muscles become bigger and bigger. And this guy just drops sudden, get a sudden death of a fit guy. Often it is because of the abuse of corticosteroids. There is a big problem in the world with obesity, both male and female obesity. Now, both in men and female, there is a balance of androgens and estrogens. If we disturb that balance, we're going to disturb reproduction. In men, androgens have a certain value, and the estrogen have got a certain value, but we need both of them. Now, we know that the production of estrogen happens in men, mostly in the testes. But we also know that estrogen is produced from androgen by the enzyme aromatase. So aromatase enzyme convert androgens into estrogens in the testes and in the brain. But there are other sites where there's high levels of aromatase enzyme, and these include the fat cells. Okay. So in men who are obese, there's a lot of fat, and therefore there's a lot of aromatase enzyme. And within the fat, you get conversion of the androgens into estrogens. So obese men get feminization because the androgens are converted into the estrogens. That's why we tend to see these obese guys having breast development, what's called again, gynecomastia, because the levels of estrogens are so. Now, if you're obese, two things happen. At least two things happen. Your androgen levels will go down and your estrogen levels are going to go up. Now, what is the impact of that of reproduction? Low androgen levels will cause low semen parameters. There'll be a high DNA damage of your sperms. It's going to be high aneuploidy rate in the embryos, and there'll be high pregnancy loss rates in your partner. Once your partner is pregnant, there's a high chance that they're going to get a miscarriage. And we also said that these guys are going to have a high estrogen level. And high estrogen in male will lead to erectile dysfunction, low libido, gynecomastia, like I said earlier on, chronic fatigue. So obesity is a problem that needs treatment. The other problem with obesity is it is just physically impossible to have intercourse. So sometimes you got infertility because they can't have sex. It's just not practical. It's not feasible. It's difficult. So they have to be managed, and there are various treatments available, various injections, various drugs available, and there's also various surgical procedures that can be done to assist our couples with obesity, both male and female obesity. There is a trend of delaying childbearing, both males and females. We want to concentrate on our profession, to develop ourselves, to make sure before I've got kids, I'm well established in my job, I've got a good bank account, which is the right thing to do. However, like women, men also have a biological clock. Although our clock happens a little bit later, but we also have a biological. There are factors that affect men from making babies, psychological factors as well, but it is important that when we discuss with men, that we clarify to them that the impact of advanced maternal age on the outcome of pregnancy is also very significant. We know that there is an increased chance of a miscarriage in the partner of a patient whose husband or boyfriend is over the age of 40. The lady, there's a high risk of stillbirth in the couple. There's a high chance that the child conceived where the male has an advanced age. There's a high chance the child could have bipolar disorder, chance that the child could have achondroplasia, osteogenesis imperfecta, neurofibromatosis, and Marfan syndrome. So it is not a benign thing that I can just have a child anytime I want to. There are implications to the children conceived in men who are of an advanced age. So you have to discuss all these aspects to our patients who come and seek for help, for other things as well. If guys come for flu or something else, one has to discuss issues of reproductive health so that they should know, because they don't. So I must tell you this, the commonest cause of male infertility is actually unexplained, idiopathic. There are many other causes, immune factors, systemic disease, sexual factors like obese guys can't have sex, infections, undescended testes, all of those things can cause male infertility, but the commonest cause is unexplained infertility. So we're all here this meeting to get an understanding as to how we should approach men with infertility. Well, there's a standard approach. One is to take, like in all medical cases, one is to take a good history. We want to inquire whether this is primary or whether this is secondary infertility. We want to inquire about the history of trauma, especially trauma to the abdomen and pelvis or the lower limbs. We want to know if a history of previous surgery, was a surgery on the testes, was a surgery, the patient has previously hernia surgery, family history of reproduction, job history, where is he working? Is he working with chemicals all the time? We want to inquire whether the patient is using drugs or has used drugs. Are they smoking? Are they using marijuana? We have to take a detailed history in this patient. It's extremely important. And then we have to examine the patients, check the body habitus. Is he obese? Is he obese? Is he lean? Look at the hair pattern. Look at the signs of excess estrogen, like gynecomastia. One has to do a penile assessment, do a scrotal assessment, and then one has to do special investigations. I think the most essential special investigation that we have to do is a semen analysis. Now, there's a problem with doing a semen analysis in the sense that it is always wrongly interpreted in my experience. Guys, we should be very, very careful to tell men that the sperm counts are bad based on a semen analysis. First of all, an abnormal semen analysis is not necessarily abnormal. Remember, we form new sperms every 3 months. If my sperms are not so great this month, it doesn't mean that's me. Could be that in the next 3 months I'll have proper sperms. If I had any problems, any condition that induced severe fever in me, that can mess up my sperm count for now. It doesn't mean that I am like that all the time. So it is important that we interpret it appropriately and we explain to it appropriately to the guys. So what the semen analysis basically tells us a few things. One, that this guy does form sperms, all right? Sperms are being made, number one. Number two, that this chap has patent tubes. Remember, men have got a lot of tubes. Ladies have got 2 tubes. Ladies have got 2 tubes. Left fallopian tube and a right fallopian tubes. Men have got a lot of tubes. We've got about 6 tubes. So this test only tells me that those tubes are patent and the sperms can move from the production site and be ejaculated. This only tells me. It also tells us about the quantity, how many eggs we have, and maybe the quality. A semen analysis does not tell us anything about the function of the sperms. And most importantly, ladies and gentlemen, a semen analysis is a poor predictor of fertility. You cannot use a semen analysis to tell this guy that, man, you're in trouble. You can never have children. We cannot do that because it doesn't tell us that. Also, it is very, very important. And whenever I do a semen analysis with the guys, I tell them, this is a semen analysis. It's not a measure of your manhood. It's not a measure of your potency. Because some guys, if you tell them the semen analysis outcome is poor, they think, no, I'm less of a man, I'm not potent. It's important to clarify this. It is not a measure of manhood or potency. We also know that there are a lot of men with normal semen parameters who will be infertile. A lot of our guys have normal semen parameters. In fact, the group we saw earlier on the graph earlier, this is the majority of men have unexplained infertility. Those guys have normal semen parameters, and yet they form the biggest group of our patients with male infertility. And there are those guys with abnormal semen parameters. As you can see down there, 52% of men with subnormal sperm parameters will achieve a pregnancy in 3 years. So we cannot tell these guys that their manhood is messed up, because remember, an abnormal semen analysis has a significant psychological impact, not only on the men, but on the whole couple. Because, you know, men have got their own issues. So be careful how you interpret a semen analysis. Now, you will get a report that the sperm count is low, which is oligo, or the morphology is low. Remember, in South Africa, we said that our morphology has declined by more than 50% in the last 9 years. Or they might say the motility, which is a big problem in Nigeria. Astino is a motility, Terato is a morphology, oligo is the proportion, the number of sperms. So if you get a sperm report that says either one of them is low, okay, that's fine. It's not the end of the world. It's one figure, one thing which is low, it's not the end of the world. Like I said, it might be okay in 3 months' time, or there might be a problem. Now, one of the commonest reasons why we get these semen abnormalities is some referred to as the presence of reactive oxygen species, free radicals in the body. Now, what causes increased free radicals in the body? It is drugs that we take, it is smoking, the pollution. If we are sick, we've got diabetes, we've got high blood pressure, systemic infection, cancer, chemotherapy, all of those things will increase the free radicals flowing inside the body, and those free radicals are damaging to our sperms. In fact, studies have shown that up to 80% of men with infertility have elevated markers of oxidative stress. So free radicals will cause oxidative stress, and that will damage the integrity of our sperm, causing sperm DNA fragmentation. Even in this group of patients, the sperm analysis might be normal, but the sperm function will be completely abnormal. Now, sperm are nasty things. Sperms don't like heat. Like I said, you put your laptops or your phones in our lab. Sperms don't particularly like a lot of coffee, nicotine, and alcohol. Sperms are very fuzzy, very, very fuzzy. But what sperms do like, they like vitamins. Sperms like zinc and selenium, coenzyme Q10, L-acetylcholine. So sperms like these things. So because of this information, there was a publication from an Italian group, an old publication, I must say, 2004, by Cavallini's group. And they took about 320 men who had either oligozoospermia, teratozoospermia, actinozoospermia, or a combination of them, and divided them into three groups. Group number one was given nothing. Group number two was given multivitamins that contain carnitine. Group number three were given supplements that contain cyanoxicam. And what they found was that there was a 38% increase in pregnancy rate in those patients who got cyanoxicam, and 21% in those patients who got L-carnitine. That's why you see today there's a lot of products that say they improve male production. You can call them by names, Prelox, Sperm Aid, all those kind of things contain nutritional supplements. Those nutritional supplements are said to be, and they fight the oxidative stress. They are antioxidants. They are antioxidants. So men get a lot of antioxidants to suppress the oxidative stress so that they can improve the pregnancy. A lot of studies were published subsequent to the study, and I must tell you, some studies were very supportive, was in agreement with the Cavallini study, but a lot of other studies did not find the same findings. Many of them found nothing, no change, if you take this product. So there's always a balance on the positive studies and the negative studies. And you can see the older studies did find positive outcome. Some of the newer studies did not find that. So the American Urology Association, as well as the American Society for Reproductive Medicine in 2022, came up with a guidelines, a position statement, because they assessed the evidence, available evidence, of this so-called antioxidant therapy on male reproduction. They concluded that the existing data is not sufficient to recommend or to not recommend the products that we use to enhance infertility. So they're essentially silent. But they also said that all those products are of questionable clinical utility. So ladies and gentlemen, if you use those products like Prelox and Spermate and all those antioxidant products, it is important that if you're going to use them, you use them for a maximum of 3 to 6 months. Don't go beyond 3 to 6 months, because too much antioxidants can lead to other problems, such as reductive stress. So you move the patient from oxidative stress into reductive stress. So if you use them, and I use them, I must admit, but only for a limited period of time, 3 to 6 months, not more than 6 months. Occasionally, the semen analysis comes back and say, there are no sperms. We find no sperms in this JP. All right, now, what is the problem? Remember, sperm production, we need to have 3 functional compartments. The brain has to be functional because the brain has to send a message the testes to tell the testes to produce sperms. If the brain does not send that message to the testes will not produce the sperms. That's number one. Number two, the testes have to be functional and be responsive to the instructions from the brain. If the testes are damaged, they will not respond to the instructions of the brain to produce sperms. And the third aspect is the plumbing system, the pipes. If the pipes are not intact, the brain will produce sperm, will tell the testes to produce sperms. The testes will produce the sperms, but there'll be no sperms in the semen analysis because the pipes are. So those are the main three things which causes us not to have sperm. So we often talk about the pre-testicular causes, which is issues related to the brain. This could be genetic conditions like Kallmann syndrome, LH deficiencies, all that kind of stuff. Maybe pituitary disease. And then there are testicular problems, could be genetic problems, could be previous trauma to the testes. And then there are tubal problems where the ducts are congenitally blocked or blocked by infection or previous surgery on the. So as we said, if the problem is in the brain, then it means that there is low levels of FSH and LH. FSH is required for sperm production. LH is required for the production of testosterone. So if the brain doesn't give us LH and FSH, sperm production is there's gonna be no sperm production, very low. And if there's no LH, there's gonna be no testosterone, it's gonna be very low. So that is secondary hypogonadism, the brain problem. And if that is the case, we have to give the patient FSH and LH. So we've made a diagnosis, so we treat these patients. These are, I call them hypo patients. We give them FSH, and instead of giving them LH, we give them HCG, because LH has got a very short half-life, and HCG has got a very, very long half-life. And FSH or LH and HCG are pretty much similar. So, but this will be done at the level of a fertility specialist. And then obstructive azoospermia is where there's an obstruction somewhere in the system. These patients basically, we have to do them by either fixing the obstruction or doing IVF ICSI, by doing ICSI, or retrieving the sperm surgically. We go directly to the testes and we retrieve the sperms. And the outcome of pregnancy, the outcome is very, very good, more than 90%, because the sperms are there, it's just a blockage. You can see whether you do IVF, whether you do aspiration of the testes, you are very, very, very good outcome, pregnancy outcome patients. Now, not all patients get tested for endocrine evaluation. The people that we have to test for endocrine evaluation, we have to do FSH and LH in those patients with sperm counts of less than 10 million, those who've got azoospermia, those with low libido, those with irregular consumption. Not everybody gets tested for this particular hormone profile. Ladies and gentlemen, let's not forget erectile dysfunction. This is also a common cause of infertility. Guys with various chronic conditions just don't get an erection. If there's no erection, then we're going to have problems with infertility. Male infertility as a window of health. You know, it's not just infertility, it's bigger than infertility. There's a high chance in those guys with infertility of developing diabetes, very high risk of developing heart conditions, high risk of abusing drugs. So we should take it seriously because it's a serious medical condition. Any man who comes to us with infertility, we should think beyond infertility. There are medical risks associated with male infertility. So now that we've diagnosed them, how do we treat them? Well, there are guidelines as to how we should treat this man. I'm going to rush through this because I don't have time now. For one, exogenous testosterone treatment. This is the guidelines. For the male interested in current or future fertility, testosterone monotherapy should not be prescribed. There is no indication to give testosterone in men who want to have children in the future. So it should not be done. What can we use in those guys? Can we use Clomid like we use in female? there's a lot of publications on this, and essentially, look at the expert opinion. Initial results support the conclusion that Clomid increases serum testosterone levels by raising LH and FSH levels without negatively impacting semen parameters. The ability to treat testosterone deficiency in men while maintaining fertility supports a role for clomiphene in the treatment of men in whom testosterone is a suitable option. So yeah, there's place for clomid in male infertility like it is in female infertility. Now, aromatase inhibitors like letrozole, which we use a lot in female infertility, also have a place in male infertility, especially in those obese guys, because we see there's a lot of aromatase enzymes in the fat. So if you give them aromatase inhibitors, you'll be doing them a good job because you reduce the amount of production of estrogen from androgen. So in the obese guys, aromatase inhibitors have been shown to be effective in managing infertility. So in conclusion, male infertility is an issue of profound human suffering. It is associated with significant physical and emotional impairment. Men also face stigma from the society. Men must access available support systems. Thank you very much, ladies and gentlemen.
Thank you so much, Dr. Biko and Dr. Mautu on his behalf. That was such an insightful presentation and really gave a lot of information in terms of what to think about. So if you would like to ask a question, you're welcome to drop a question into the chat or into the Q&A. I do see there are still some other slides here. I don't know if Dr. Mautu, you wanted to go through these slides?
No, not at all. It's just a bit of an add-on as to how to educate our young men into middle-aged men. So it's not just a once-off thing. I think there's currently as we speak, there's a big movement and spotlight on male infertility. I mean, in the past 2 weeks, we've had 3 big congresses talk about male infertility specifically. So I think there's a move to focus on the young man going forward. I think it's a big issue at the moment.
No, for sure. And I think one of the questions that I wanted to actually ask was in terms of when should then men be starting to think about fertility? I think, like Dr. Biko said at the beginning of this presentation, women tend to think about it quite early, and most women around about 30, 35 will, if they haven't conceived by then, are really going to start thinking about it. But for men, when should they actually start thinking about it if they haven't yet conceived?
By the way, Dr. Pizzi, that's already late for 35.
I know. Yes.
But there are different publications that actually speak of advanced paternal age, as Dr. Biko touched on. The most accepted definition of advanced paternal age is actually the age of 40. So between 40 and 45, if you don't have children, you should start getting worried. But ideally, remember that, I mean, we're saying this from a semen parameter point of view. Historically speaking, human beings fall pregnant at the age. And that's just the truth of it. So I think by the time you're 35 and you don't have a child, you must start thinking about it. I know that the world is going a different direction at present. It's something we need to look at.
That's a very fair point. That's a very fair point. No, thank you so much. Okay, I'm just looking at the chat to see if there's any questions coming through. There's been requests for the presentation, and just for everyone's knowledge, we do put these presentations on the Netcare YouTube channel. So if you are looking to review the presentation again at any point in time, it will be available on that channel. All right, I'm not seeing any questions in the chat, Doc. So I think, barring any questions, we'll call it a day here. But thank you all so much for joining. Thank you for a really, really insightful presentation. I think it was very, very well covered and a very interesting topic, especially in this day and age. yeah, I think if there's no questions or nothing coming up in the chat, then we'll call it here.
Thanks a lot. Thank you for the invite. It was quite an interesting topic. Thanks.
Thank you. Alrighty. Good night, everyone. Bye.